It's a great era and a day for partnerships. I was reflecting on this panel before coming here, I thought to myself, why does it need to be so hard in the healthcare sector? Because some of us have worked in different other sectors or regulated sectors of the economy, worked in different government positions. As you come to the healthcare sector, there are all sorts of interesting challenges that occur that don't really occur in other sectors. There are PPPs in infrastructure projects. You build subways every day. You have road building projects, all of which are what we'd consider to be shared value. There are models around these. There are, and we'll focus a lot on this, incentives that make sense for all of the parties. Why does healthcare need to be so hard? Well, in any case, one of the reasons why it is more difficult than it needs to be is because we have a poor understanding over this issue of incentives. What it actually brings both parties or the multiple parties actually to the table, and for them to be very clear on those objectives, to put mechanisms around some of those things. And that will go, everyone today is doing sort of their part, but this will go, I think, a long way to explaining why things work or don't, or where we could be as opposed to where we actually are today. So, we have a fantastic panel, which each one of the panelists is going to lead off with about 7 to 10 minutes of remarks. Dr. Jeanette Vega will start, will be followed by Gary Cohen from BD, and then the infamous Simon Bland, jack of all trades and influential in all. So all the same, I think it'll be a very interesting panel, but very quickly, I'm going to turn over to questions and answers. And I really want to make sure that our colleagues, not only with the forum, have an opportunity to ask questions and answers, but our colleagues that are sitting right in back of them, equally so, have a question or two, and to stimulate the discussion a little bit further. So without any further ado, let me invite Dr. Vega to the stage, the director of FNASA, Chile.
Hi, good morning. Let me begin by saying that I'm very happy to be here today, and many thanks to the organizer for the invitation. I am the director of the National Health Insurance Agency in Chile, which covers 80% of the population of the country. And I'm going to talk a bit about some of the complexities of the public-private partnerships from the point of view of a government, and immediately after that I will show 2 examples of what I think are very successful partnerships. Of course, we know that these priority public-private partnerships are very complex instruments, because basically they require some competences that are or needs to be present in government. These involve having a system for assessing value for money, making sure that we are able to classify, measure, and allocate risk, and also, as one of the presenters before said, is that we need to be able to measure and allocate risk and to the party that has more experience. From my perspective, the main requirement to introduce public-private partnerships in the public sector is to have a sector that has good governance. And this is a very complex issue because it means having institutional stability and effectiveness in decision-making, and also it means to be very clear on what are the specific needs of the country. The other, which is a consequence of this, is that in government we have to have a very clear, predictable, and well-regulated legal framework before beginning to invest heavily on public-private partnerships. In particular, we have to be clear of what is the level of profitability compared to the specific sector average that we are willing to pay or to accept in any partnership with the private sector. Some of the things that we usually ask ourselves when we begin to do some business with the private sector are, what are the comparative costs of operation when we do it using the private sector as compared as if we do it using the public sector. Also, we try to do a very careful risk assessment, ex-ante risk assessment, and then make sure that the right types of risk can be shared or transferred to the partner that basically is able to ensure more value for money. We also usually do and assess the risk, cost, and quality trade-off that needs to be managed by the public sector. And also we try to define clearly what is the output that we want ex ante. So let me just, with this very brief introduction, turn to a couple of slides that I'd like to present to you today. So just, this is a bit of a complicated slide, but just to let you know how does the Chilean health system work. We have a system that basically every citizen that works in the formal sector pays part of their salaries to the national health insurance, which is 7% of their salaries. For those that can't pay, the government paid using general taxes. So in other words, every citizen in Chile is insured, and the people can basically opt out and go to private insurers, which are called the ISAPRES, or they can go to the National Health Fund, which basically we do all the pooling, purchasing, and administration of the health budget and in the country. So this is the way that we basically insure the population, and then the different population basically is goes to public or private providers. Of course, given that the way that the citizens can opt out is it has to be an agreement with the private insurers. There is some sort of a scheming, and we basically are in charge of most of the indigent population, plus lower and middle income people in the country. And the upper and high income workers and their families are usually insured by the private insurers. And then we have a national health system that provides services, hospitals and primary health care services, and we also have private providers. And what we are doing right now is sort of innovating in strengthening the connections of FONASA with the private providers, because we have a shortage of, for example, beds and services that we believe that if we design well the partnerships, we can take advantage of the private sector, and also the private sector can enlarge their business model. So this is one example that I'll show you, and this is a large example. What we have done is that we have basically changed the way that we pay providers, and we have introduced in the country DRGs. Now, the interesting thing is that we have done this, with the goal of basically rationalize and improve the set of payment system for public providers, but at the same time, we are using our power to purchase beds, basically care, hospitalized care, to purchase that from the private sector. And we are purchasing around, we have a shortage of 2,000 beds in the country, and we are purchasing services, but we're basically equalizing the way we pay public and private providers using DRGs. And the only difference is that we change the base price that we use for the public and the private sector. So basically, we have used a strategy that the first thing that we did is that we defined the criteria for prioritizing the different steps. And we said we need to have, first of all, easy wins that put FONASA on the path to achieve our goal, which is basically to financially cover all and make sure that citizens have access to care. Secondly, that is feasible and politically and practical and so on. The second was to avoid shocks to allocation of payments, and then with this we had to build, and this was very good because it allows us to build much more stronger information systems. So this is one example, and this is the other one that I think is more interesting to you given what we have been discussing in the first part of the morning. We are basically introducing chronic disease care by using telemonitoring for case management in old, and this is a quite interesting thing, because what we have done is that we have introduced in one health system in the metropolitan area that covers a total of more than 1 million people. We have introduced in telehealth services for chronic care of diabetic and hypertensive patients. And we have introduced this using a specific company that is working with us. So basically, this is the way that the model works. Each primary health care center offers to all patients in control for diabetes and hypertension the possibility of enrolling for this program at home. And the program, FONASA basically, we finance the program on a per capita basis, based on a definition of a specific basket of care according to level of complexity of each patient enrolled. The frequency and type of a specific care activities is defined by the complexity of the case, with the goal of keeping the patient clinically compensated. At entry, each patient is monitored for 15 days, which allow us to classify them to actual stage of disease. Then we provide each patient with a set of services, including biological monitoring from home, transfer to the information to a central care unit that is managed by the private partner, plus the use of SMS, phone calls, and virtual communications to manage their symptoms and biological parameters. So we have the patient at home. We use these devices to monitor their blood level of sugar and also their parameters for blood pressure, and this is sent to this center, and then information is provided, or interactions or adjustment of the dose or anything that is needed. If the patient requires consultation or hospitalization, he or she is referred to the public facilities of the health system, fast-tracking them by online communication between the private and public providers. So this is the follow-up, and we also provide education. Now, the interesting thing is that we are talking about more than 1 million people with a prevalence of hypertension of 26% and a prevalence of diabetes of around 8%. So it's a considerable group of people. And what is probably more interesting for you is that these are the clinical and economic results at 6 months. And you see that for each group of patients, basically these are the patients that are compensated. There is a very big increase in the number of patients that are compensated, and then there is a very decrease in the patients that are not compensated. And if you look at the initial measurement, 7% of the initial parameters went up, 60% it's the same, but 33% decrease. And compare with the clinical usual treatment, we have had an average savings so far of 56% in the patient care. So this is the type of things that we had been doing in a country, again, that is mostly a public finance system, that you can do and also lead the system toward preventative and promotion for healthcare. So with that, those are my introductory remarks. Thank you.
Gary Cohen from BD.
Thank you, Trevor, and good morning, everyone. And I just want to say how impressive that program is of telemedicine for diabetes care. It's the most progressive I've seen, and it's something I'd like to share with others. Unfortunately, I didn't bring my computer today. I regret that I didn't, because what I'm going to share with you, I could have shown you really nice slides, which would have been much preferable to looking up at the stage at me. But that being said, I'll be able to share the same information. You know, I have a day job at BD, which is a global medical technology company, just under 50,000 people in 50 countries, and I've been there 32 years. And I also do a number of other leadership roles. I'm responsible. I'm acting CEO of GBC Health, and I'm on the board of the CDC Foundation and UNICEF and a number of others, which has allowed a wonderful perspective working across sectors, and we have considerable experience in public-private partnerships. And I have to say, this is going to be a practitioner's view. We have established new business models, and I would even say new management science as a result of our experiences, but it's all been empirically based. We've learned what we've learned by actually implementing and then extracting from that the observations and the models. And let's also keep in mind the term public-private partnership is a relatively new term in the way it's used today. There was an historical version of public-private partnership, let's say prior to the late 90s. We had pioneered one of the early partnerships with UNICEF back in the late 90s, which is, I believe, the more modern, if you will, form of public-private partnership. And even the term global health, in the way it's used today, is a relatively new term. For us, a sort of a watershed event occurred in early 2000s. I traveled with Tommy Thompson, who was the health secretary at the time, and Richard Holbrooke, and a delegation of 100 health leaders, the leaders of all the major health organizations in the world, to sub-Saharan Africa to study the HIV and AIDS pandemic in December 2003. And it was a phenomenal trip for all of us. And coming back from that trip, we within BD mapped out where were all the areas that we could help in a manner that perhaps was being overlooked because there was so much focus on treatment at that point, but not things like health system strengthening and laboratory testing and so forth. And we formed what is now our global health function back in January 2004. And at that time, the term global health was not really being used in this manner. So let me actually jump into some specifics here. At this point in time, we're operating around 20 public-private partnerships in various stages of progress, and they fall into three primary categories. One of them is social investing, which many people call philanthropy, where the nature of our role is as a donor, but as a hands-on active donor. So we partnered with UNICEF in the late 1990s to eliminate maternal and neonatal tetanus. We've supplied on the order of 60 or 70 million safe immunization devices and about $10 million in cash, but we've remained a partner in that. That would be a philanthropic partnership. The second is what we called CSR, what would be commonly called corporate social responsibility, where we're using our core competencies. So, for example, we have a partnership I'll speak a little bit more about with PEPFAR and the CDC called Labs for Life, where we're strengthening laboratory systems in 5 countries in sub-Saharan Africa and also in India. And we have another partnership with the same partners on strengthening phlebotomy practices, blood drawing practices, both for safety, accuracy of diagnosis, and transport. And it seems like a very basic area, but it's done improperly in most developing countries. Those would be examples of CSR. We're using our know-how, but there's no direct commercial gain. The third would be shared value creation, which was mentioned earlier, where intentionally, specifically, you're focusing on unmet societal need in a manner that also provides business opportunity. And we have an example there I'll share with you at the end in trying to address maternal and newborn mortality reduction and bringing innovations to scale for that purpose. So since time is short, I'm just going to give you a brief preview of each of these. So on safe immunization of children, back from the late 1980s, we started to develop the first auto-disable immunization device. It took about 9 years for that to go from embodiment to full scale. Between 1999 and today, about 6 billion immunizations have been administered safely, primarily to children, using that type of technology. And it essentially eliminated an entire category of disease spread, very quietly because it's not well known. That would be an example of using innovation through partnership. January 2004, we partnered with the Clinton Foundation to make CD4 monitoring widely accessible, measuring the immune system of people living with HIV and AIDS so that you would know when to begin antiretroviral therapy. This was right on the cusp of the scale-up of antiretroviral therapy. That was a shared value initiative. We offered very low access pricing, but it opened up opportunity in what ultimately became 55 developing and emerging countries. And within a few years, CD4 testing was widely accessible. In the process of that partnership, we trained over 8,000 laboratory technicians on how to do immune system monitoring, contributing to laboratory system strengthening. With that know-how, and also in 2005, we had established a volunteer program within BD where we would deploy our associates to developing countries to help strengthen health systems locally. Then we entered into the first laboratory system strengthening partnership with PEPFAR, which was more broadly based, and really the objective there was to move laboratories towards accreditation. Very few labs, particularly in sub-Saharan Africa, were at an accredited level. And there was a 5-step process that when they completed that process, they would be ready then to work towards accreditation. And that partnership has been highly successful. It was a 5-year partnership renewed again in 2012 for an additional 5 years called Labs for Life, one of the more successful partnerships of that the State Department in the United States has entered into. And just to give you a quick sense of some of the outcomes, we were able to reduce turnaround time for tuberculosis testing in Uganda from 3 weeks to 3 days. We were able to identify 14% of TB treatment cases in Uganda as multiple drug resistant, and anybody who's familiar with TB knows how important it is to identify MDR TB. We worked in Ethiopia to facilitate implementation of a nationally integrated specimen referral and handling system, including involving the Postal Service in transport, and we supported development of a national lab quality system in Mozambique. So we were working very much in the spirit of public-private partnership at the national level with the national government, with CDC on the ground, hands-on, our people working with CDC people and the government to implement. Let me shift now, and I know I'm going through these quickly. Before I shift, I'm going to mention one other, a partnership we entered into with the International Council of Nurses back in 2007 on wellness centers for health workers. This was a response to the migration of health workers out of developing countries to the West, which everybody associated with their desire to make more money. But if you sort of dug underneath the surface, you found that the intolerable working conditions and the high potential of contracting disease occupationally in the healthcare environment was a big factor, still is a big factor in health worker migration. And so we entered into this partnership to establish wellness centers. PEPFAR ended up joining the partnership as well, and also the Stephen Lewis Foundation, to establish sort of a safe haven where health workers can go for very discreet testing, counseling, and treatment. Their families could go as well, so they didn't have to be faced with going into their own clinics to be treated if they contracted a disease. Swaziland was the first country we implemented, and we were able to track migration of nurses going down to 0 in the country as a result of establishing a wellness center. A highly efficient, high return on investment. And I would say that having a healthy, secure, protected, and trained health workforce is the most fundamental foundation of a health system. Without that, you're just building on a weak foundation, so that makes this particularly critical. A few years ago, based on the realization of the 2 areas of real unfinished business with the MDGs, which I would characterize as maternal mortality and newborn mortality, as of 2013, newborn mortality represented 44% of all under age 5 mortality, 2.8 million newborns dying first 28 days of life, and a substantial majority of that in the first 2 days of life, not including another 2.6 million stillborns, which were not even necessarily tracked, and also 289,000 women and girls dying in childbirth, and more than 10 million having severe complications. If you look at MDGs 4, 5, and 6, those were the 2 areas that really lagged, and it's not surprising because they've required a different type of intervention. The phenomenal progress with the EPI and Gavi was not going to address that issue. The phenomenal progress with insecticide-treated bed nets or the work to extend antiretroviral treatment. This really involved the ability and capacity to do the necessary interventions more in an acute care environment or to task shift with innovation so some of these issues that are causing these problems could be dealt with outside of an acute care environment. So we were approached by the World Health Organization at Davos in the World Food Program tent in January 2012 with an innovation that you may have heard of if you watched the news. It was on the front page of the Times. It was invented by an automotive technician from Argentina, and it would replace forceps and vacuum assist for obstructed prolonged second stage labor, which is one of the primary causes of both maternal and newborn mortality. WHO championed this device in the Saving Lives at Birth competition and was looking for a partner, and fortunately for us, our reputation preceded us. So even though we weren't involved in obstetrics and gynecology, they approached BD, and with a lot of internal debate, we decided to develop something way outside of our core areas of business, but within our core competencies, and it's called the Odon device. It's in development and clinical testing now. And based on that, and also based on this unfinished area of accomplishing the MDGs, we determined that it would make sense to broaden it and really put focus on using our capabilities to develop a broader range of innovations that can address leading causes of maternal and newborn mortality, taking advantage of the scale capability that a large global company has. And I would say most of the innovations that were being stimulated by Saving Lives at Birth, which has done a phenomenal job, we're not getting past the initial concept phase, because getting them to scale, doing all the work to get them to scale, is actually the majority of the work. And we're hoping to set a model and precedent here. And as we speak, I'm right in the midst of negotiating 2 agreements for our next arrangement, which would be to develop 2 point-of-care tests to address 2 of the leading causes of maternal mortality, preeclampsia and gestational diabetes. And we're working with the Global Health Investment Fund, which is one of the early impact investing funds. And again, I would say this is being done empirically. We're developing the models as we implement, but this is one of the earliest examples of blended finance. And if I showed you the model, which unfortunately, since I don't have the slide, I can only show it to you like this, that we're using for the Odon device, it's truly a case of shared responsibility for the work, shared investment. WHO is doing the clinical studies, BD is doing the development work. We're working with the Federation of International Gynecologists and Obstetricians on the usage guidelines, training that they'll push through their chapters. The Gates Foundation is involved in this, and we're thinking well ahead in terms of access planning. We've had interaction with Save the Children about reaching areas, last mile reach per se, that we don't reach with our own organization, even though we're very geographically dispersed. So these are establishing sort of the next generation models using blended finance to, and again, this would be a shared value example where we hope to have a sustainable business model with high access in the highest burden countries. But interestingly, this new birthing device is also an opportunity in the developed world. So I know I ran through that very quickly. We do have a lot of experience to share here, which we share very openly and eagerly because we're also trying to stimulate other private sector players to engage in this type of work. Thank you.
And then finally, Simon Bland, who will speak not only from the perspective of UNAIDS, but also as a former very senior official within DFID UK from the donor perspective. Thank you, Simon.
Thanks, Trevor, and I'll speak from here. And it's a great privilege to be on this panel, and Jeanette, to see that very progressive program there, and Gary, to hear you race through these incredible innovations is really very inspiring, and part of why being part of a forum like this is important. I was asked to reflect really as in terms of looking at the incentives from a donor perspective, my time at the Department for International Development in the UK, and its interface with 2 sort of global funds, Gavi and the Global Fund to Fight AIDS, Tuberculosis and Malaria. And it's funny, as I joined the UN, I now sort of, I'm not part of negotiations. I'm told, you're part of the UN, you're no longer a member state. And I heard Rifat this morning saying, well, I'm not quite sure where I am. Am I this or this or this? And maybe that's the first lesson. We're all people, we're all us, we're all who we are with our experiences, and breaking down some of these prejudices, if you like, or uncertainties or misunderstandings between public and private sector is a big first part of this shared value and creating trust, and we don't do it well enough. And I know from the UK's perspective, our engagement with the private sector was almost a taboo until the mid-1990s. It was perceived as a conflict of interest. It was perceived as government giving a helping hand to certain parts of industry over others, and was something that we were clearly not comfortable with, and clearly didn't have the language, nomenclature, or skills to even really engage. So there was a challenge back then. I'm 2 years removed from DFID, and there's nothing quite as faddist, I think, as development assistance. They go through cycles, and things come and go and generally come back again several times. So there's a little bit of a historical perspective there. But, in my time, I can think of, how we used to use project assistance, program assistance, sector-wide approaches, sector budget support, general budget support, and they all found favor at different times. And what inevitably drove these things was politics, and it was domestic politics at home and public opinion and perception at home. And so incentives are really driven, from our perspective, by that national debate, by that perception. As we come to see the negotiations around the Sustainable Development Goals and financing for development, we must recognize that official development assistance is a tiny sliver of the resources we're talking about. So we don't want to get too ahead of ourselves thinking that, the donors are, the savior and are what's going to give us global health. I think we have in the past. I think there's an increasing recognition. And if you just look at development financing in Africa, official development assistance in 2012 was 50 billion. Domestic resource mobilization was 530 billion. So health systems are going to be funded by domestic resources through whatever financing mechanisms. And the challenge of the future is figuring out how development assistance can be best focused in a way that goes to where the need is, to address those market failures, to create the right incentives for broader leverage and broader change. And I think there's an increasing recognition for that. Nevertheless, part of these debates that are going on financing for development, and one of the contentious issues will be, will the North, the OECD NAC countries, live up to past commitments of 0.7 of GNI to development versus the challenges of tackling illicit flows and domestic resource mobilization? It maintains a big political contentious issue that is being debated again today as we speak here. Now, I was very proud in the UK as working for a government that represented the first G7 country to hit that Monterey Consensus commitment of 0.7 GNI. And that wasn't easy with politics at home, but there was cross-party support for that, which still surprises me. And not only that, they legislated for it. So it's now part of the legislation. And so the UK, thinking about finance right now, is trying to get others to join that group because they're politically exposed at home, being the only country from the G7 that have reached those international commitments. Now, there will be commitments, I'm sure, coming out of Addis, but they will be longer term, and so there's a fragility to that investment. The other dimension for this, the UK, much of public opinion will feel like development assistance is charity. Development assistance is something that, yes, is meeting societal needs, but it's something we're giving. We have plenty of societal needs at home that will compete for this. But the best way of meeting that is to go and support local charities and local projects. There's a broad perception that that's what development should be like. And of course, it's not the way we do development. But the idea is that we would put a large amount of our increasing budget into the international system, or into big public-private partnerships or big global funds, is also another hard sell to the population. So the House of Commons International Development Committee just met and issued a report at the end of last year and said the UK has had a good reputation for investing in health systems globally. Through its bilateral programs, we've worked with national governments to try and build those systems, but we increasingly now rely on the international system, including the likes of the Global Fund and Gavi, to do this. And that's a risk, and that's difficult for us. So there continues to be a job to do to sell this. The UK also looked at the proliferation of the international system across all sectors and did an assessment of 43 international organizations and assessed them in terms of relevance to UK development priorities, but also in terms of the value for money, their cost consciousness, and their ability to deliver results. And no surprises, those funds that are single issue focused, that are somewhat vertical in nature, like Gavi and the Global Fund, do remarkably well. They come out as very good value for money. And I was a big supporter of those reviews because I think it introduces some competition and edge around performance and efficiency. But it also misses some of the systemic issues of how the broader international system comes together and how, for example, Gavi has to rely on UNICEF, Gavi has to rely on the World Health Organization, and has to rely on health systems and countries to actually deliver the results. So we've got to do a much better job of explaining what a health system is, why it's important, how you build it, how you strengthen it, and how you're only going to get the results by doing that. On the boards, and I guess the UK has pushed health system strengthening investments from both Gavi and the Global Fund, but in all honesty, those investments have been a tiny fraction of the resources that those institutions have invested. They will talk to the spin-off benefits of the programs on malaria and TB and HIV for health systems, but their actual investment in those systems has been very weak. There was an attempt, I thought Rifat might mention it this morning, but from the Global Fund and Gavi and the World Bank and WHO, to harmonize their investments and work on health systems. They set up something called a health systems funding platform that recognized that all these institutions are working with host governments to, yes, deliver their issue results, but also to build the health systems for doing that. And I have to say, it was sort of one of the classic examples of process taking over. And I think we spent institutionally 2 years trying to come up with mechanisms simply to harmonize our approaches, to health system strengthening in countries. There have to be some lessons there. It is still imperative, still important, and we haven't done it. And I guess one of the biggest lessons for me is you look at countries like Rwanda and Ethiopia. Strong leadership, strong governance. Take the Global Fund, make it work for them. Take Gavi, make it work for them. And that's where we see these systems really moving ahead of pace. So I think one of my strongest lessons is going to be, how do we help countries build their capacity, build their ability to negotiate, build their ability to lead and direct the resources, the attention, the technical assistance, and the capacity building in a way that really meets their national contextual needs. And finally, I think we're going to see, and what I take great inspiration listening to Jeanette and Gary, I think the future is not going to be, the massive expansions of the global funds and the Gavis of this world. I think they're here to stay. I think they have a continuing role. But the future is going to be national and subnational partnerships that really are sort of driven by context, driven by sort of good leadership. And I think that's where the innovations and that's where the system is going to get strengthened.
Thanks.
Super. Thank you so much. All right, so we've got about a half an hour in total. I take the prerogative of the chair to ask two or three of the first questions, but please be at the ready here. Jeanette, there's a fantastic example of private-public partnership in many key respects. Could you let us know a little bit more on what things you might be discussing a little bit more out of the public eye to change even the accomplishments that you've had here? I doubt you're sitting on your hands and only celebrating success, and you're looking at the future of different mechanisms, different perhaps regulatory policies to bring greater incentives into the sector.
Yeah, well, the main discussion, I would say probably in countries that are middle income or beginning to be developed, is to change the mindset of policymakers, because we have had extremely, and in particular I'm talking about Latin America, extremely bad experiences in former partnerships with the private sector. And that is basically a problem when you try to introduce doing things with the private sector. And it has to do with what do you believe is public, the definition of public and private. And what, for me at least, it has been extremely difficult is to manage that tension. Because I'm from a country that has a history of public health, yes, and the national health system, and a political history that is quite difficult. So, and we are, of course, a government that is a left-center government, it's a social democrat government. So what I've been discussing in the newspapers and in the media is that for me, the definition of public is that you do things with a public vision, and not who provides services or who finances them. In other words, I put always this example, nobody would say that Canada is a private health system, because that's the thing. Every time that we try to introduce innovative things with the private sector, people would say you are privatizing the health system. So we are basically saying, well, nobody discusses that Canada, for example, is public. But then all the provision of services is done by private providers. And I usually put another example that is in our system. I say, I don't think the current Chilean health system is a public health system, at least for the provision. It is completely privatized. Because what is happening is that the way that we are doing business right now is that we are contracting the same physicians that work part of their schedule as public employees, but the rest of the time they are basically being contracted to service, to do the surgeries and so on. So for me, that's the biggest issue in the current provision of services in Chile. So I rather developed a public-private partnership with some of the companies that can offer that care in a much more efficient way, that continuing basically supplementing the income of the public physicians, or the private physicians using the public facilities, as I call them. So that is one issue that is always there, the issue that you are in fact privatizing the government or the health system or the education system and so on. And the concept of social responsibility that basically the private sector can't negotiate with the public sector, and the negotiation is not only about how much profit do you have, but also how much social impact do you have. It's a conversation that is, I would say, it's key if you want to make business with governments, in particular in some of the regions of the world.
Thank you. So I want to have actually a private and public sector, different perspectives on the following question. And actually, the way you started is it's not easy to talk about difficulties. It's not easy to talk about troubles. But as we're really in the early stages of mapping out private-public partnerships in this type of systematic way, particularly in the context of this forum, it's important to talk about past examples of which we can improve upon. Gary, you have an incredible portfolio, an incredible amount of accomplishments with governments, supranational, national, and Simon, thank you for bringing in the sub-sovereign perspective on this. I'd like to, have you draw upon maybe a couple examples. Please, feel free to cleanse identities, locations, etc. In so doing. But and then, obviously, what can we learn from it? And Simon, from your perspective as well, you've seen these at, if you will, at a structural level partnerships, whether or at a transactional level. Feel free to comment from the public sector perspective.
So just to clarify the question, Trevor, you'd like me to provide some other examples of
failures.
Of failures. Okay, I missed the word failure.
No, sorry. This is a failure analysis.
It's a failure analysis. Okay.
Typical in engineering.
All right. So you're not going to be fully satisfied with my answer. I'll say right up front,
good.
Because we work very hard to avoid failures. Mm-hmm. And I would say of all the public-private partnerships that we've been engaged in, and most of which are still active. I pulled out the list in front of me of 20 in various forms. There's only been one that had less success than we would have liked, but I would not characterize it as a failure. And it was one of our earliest ones, and it was to help train health ministry officials in a particular country on management systems. And the reason that we ended up in that partnership, we were really seeking to enter in for health system strengthening and to do more of the things that we were really offering to do and ended up doing through other partnerships like Labs for Life. but the collaborating partner on the other side had their own version of what they, version is not the right word, own objectives. And it sort of morphed into this, and we recognize the legitimacy of it. It's very important. But it didn't work as well for a number of reasons. The level of turnover in the health ministry in that country. There were some cultural issues, I would say, in terms of speed more than anything else. You know, the people, and we had relatively limited resourcing for this, and the people running it wanted to get on with it, and the people on the receiving end wanted to take their time, to put it in very basic terms. So that was the only one. Now, but like anything else, I don't want to overemphasize the negative or the failures here, because everything else we've worked on has worked. And they're broad-reaching. A number of these have gone to scale. I didn't mention before, and some of you may be familiar with this, but our know-how in working primarily in health system strengthening ultimately, I would say, spilled over to a partnership on human rights to address sexual violence against girls, which was something I founded in 2009, and then BD joined in about 10 months later, and 5 UN agencies are partners, State Department, PEPFAR, CDC, Government of Canada partners. And we've, in 5 years, taken this partnership to scale in 17 countries, in Africa, Asia, and the Caribbean, and soon in South America as well. And it was by applying the same principles and actually being able to get it to scale. And so let me share a slightly different answer on some of the principles. Trust is extremely important. The point earlier that was made about, our government's corrupt, our business is greedy. I mean, yes and yes, that's the sad answer, but that doesn't mean everyone in government everywhere is corrupt. It doesn't mean every business person working in every company is greedy. It's a matter of finding the right people. And when you operate by highly ethical standards and people get to know that, first thing is they don't start to even waste their time trying to get you in an unethical direction because they know it's not going to get anywhere. So a big part of this is finding the right people. Another, and here we're talking about leaders and champions, is the alignment of purpose and motivations. The things that have worked best, the underlying motivation and the reason that was being done were so highly aligned that it pervaded over everything else. So even if a company has an objective, if it's a shared value initiative, to say to make this viable, it has to be sustainable as a commercial model, still the primary objective, if you're addressing an unmet need, has to be the unmet need. The commercial outcome is maybe a necessary byproduct, but if it's the primary objective, it'll distort what's being done. By the way, one other thing I'll mention, and then you can move on. Some companies enter into these for the reputational benefit. They get called out by the Secretary General or some other major venue, which is very important, by the way. But if their underlying motivation was the reputational benefit, they already got it when the announcement's made. After that, it's a law of diminishing returns. They don't have the incentive to actually follow through. Now, part of this is the accountability, so holding organizations accountable, maybe withholding some of the reputational recognition until things are achieved, but it goes back to the underlying motivation. There are many things that we've been involved in that have never been known. They're not publicized. We're not doing it for the publicity. When we responded to the Ebola outbreak, which became an epidemic in West Africa, we were the first global company to respond. We never told anybody about it. And then one day President Clinton starts talking about it because he heard about it from somebody else. It's because the motivation wasn't the recognition. The motivation was to take our capabilities and apply them in an area of need. So I think those are some of the operating principles that help you avoid failure rather than find yourself in the trap of failure.
Exactly. The Japanese have an expression called Indoku Yaku, which means changing poison into medicine, and you've done precisely that. Simon?
So, given that hunger for results of of sort of a donor constituency population, we're pretty risk averse, actually, which is a little bit contradictory given the business we're in, right? Development's not easy. People get left behind for reasons, and tackling it is just not straightforward. If it was straightforward, it would happen. And yet trying to make that case, make that fairly nuanced case to a population tends to be quite difficult. So we need twin tracks. We need to, and certainly when I was working in Kenya and Somalia, and our programs on health there were two tracks. There was a track that you could clearly identify delivery of results, and we would use intermediaries, we would use the PSIs, we would use NGOs, we would work closely with government on the delivery of those results, but we would also do some broader things that were around enablers and trying to build a system. But what people really needed to know was that you were delivering results. So you have to mitigate a little in that way. The perceptions of risk are very high. You talked about corruption and illicit finance, and the perceptions are way out of whack with reality. If you look at sort of recent research of 5,000 infrastructure investment projects across the globe, they show very little difference of return from whether it's a developing middle-income country or a low-income country or indeed a high-income country. But the perceptions of risks of returns from those are very, very different. And so we have to challenge that, I think. In terms of failures, I think, I talked about this attempt to have a more coherent approach to health system strengthening across these global partnerships, which was incredibly laudable and actually you would think is pretty straightforward. This is the bank and WHO and Gavi and Global Fund, often all working in the same country, in the same sector, with the same interlocutors. I remember talking to a former minister of health in Mozambique, and he said, I thought I was becoming the Minister of Health. I was actually becoming the minister in charge of donor coordination. And so the motives for doing this were absolutely laudable, but it was almost a microcosm of the problem, the inability to get through that with a set of practical guidelines that work. And that's why I go back to that sort of country drive and country leadership being really important. I think the next one I'd just quickly mention is that there have been a lot of really creative, clever, and impactful innovations in finance. And if I just look to Gavi for the international financing facility for immunization, it front-loaded long-term donor funds into allowing a rapid rollout of pentavalent and others. And really short-circuited many years of development, and a great success. We used an advanced market commitment for pneumococcal vaccine in the same way, and so great innovations. There was another one called Massive Good that was trying to look at global airline taxes, and it had high aspirations for large sums of money. And they tried and tried and tried for probably, I think, about 3 or 4 years, but then did give up. And I think actually there are lessons in that, and I think that's quite encouraging. I know my government, when I was in the UK, supported it for political reasons, but also some ambitious reasons as well. But there was a recognition that it tried and failed, and actually that didn't then translate into we must never try that again. And I think that's the real lesson, is to try and create environments where you can take some risks, where you will not always succeed, but not to let those failures actually stop you continuing to try to innovate.
Perfectly said, Simon, thank you. All right, so to the crowd, do we have any questions on the inner circle or the outer circle? To begin with, Joe, and let me stop before you answer the question, ask the question, to extend our deep appreciation for opening up the New York Academy of Medicine, in this way to all of us for not only one day, but actually 3 days. So thank you again for your hospitality. Please.
It's my pleasure. Come back anytime. I want to ask Dr. Vega a question. You started your presentation with something I think is really crucial, and I wanted to hear the sort of narrative of how it happened. You said that one of the really important parts for government or governance is capacity to manage strong legal frameworks. We could add regulatory. That's come up here a lot. And sort of information that allows you to assess the risks and opportunities that are being offered to you. And I want to stay with this capacity to manage and infrastructure to manage, because obviously partnerships are best when it's strength to strength rather than, we've talked about this power imbalance and a whole set of issues. So, and obviously Chile is a middle to, developed country at this point. How has that emerged in the governmental infrastructure of Chile? Was it a conscious effort? Was it by accident? Was it engaging donors in ability to work on that, getting expertise from the private sector? Could you talk about that arc a little bit so we understand how you developed to where you are now?
Yeah, the summary is it emerged by learning from failure. Because this is a very, very, very difficult process. And we have had extremely big failures in Chile. You have to remember that we had been sort of the guinea pigs for several social arrangements. We were the first country that tried to introduce socialisms by democracy. Then we were a country that had a dictatorship for 17 years, and during that dictatorship, we were the guinea pigs for several of the initial experiments of the World Bank in terms of the creating a social space that can be led to a free market. And I think we have learned from both experiences. The thing that in all the failures, in all the projects and partnerships that have failed, the key issue has been lack of governance and legal frameworks to basically be able to manage the relationship. And that in reality translates into very bad contracts, very bad monitoring, and very bad measures to, when things go wrong, to basically get rid of the contracts or to improve in cases needed. So, for example, let me just give you one example. We have had, like, I would say, more than 20 years of failure in implementing good health information system in the country. And now in FONASA, we are introducing our third try in health information system for the whole country, integrated 360. And the main issue there was that because of some of those experiences, then people say, all right, we are not going to get into business with any company, we will do it our own, and it's going to be proprietary and we won't have any problem. Of course, when you do that, you are basically creating things that are in the market, that have been proved and are in the market for years. And of course, you don't have access to any big data, right? Mm-hmm. So we introduced a partnership with Oracle, in fact, and we are redesigning the whole health information system for the country, but we are doing it from a financial perspective. So given that we are the payers, we are basically asking the health system to provide with the specific information, and we are reorganizing the whole health insurance in the country using basically two very well-known and that have been proved products of Oracle. That one is what is called OIPA, which is Oracle, something that creates basically the accounts, and the second one is the Oracle Health Insurance software. So the most difficult part of that was to convince the people in FONASA, the workers, and the general public that why this model is going to be successful, and this is not privatizing, because basically we have a very clear underlying objective. For us is to introduce a system that works. For Oracle is to basically introduce a system that they have working right now in one country that is quite influential in the region. So if we do it right, it's going to be, in addition to the margin of commercial profit, it's going to be a win-win situation in terms of the outcome, which is to improve health system. It's a very long answer to your question, but I'm basically trying to say it's from failure, and that's usually the way it is.
Okay. Seems like we have some competition outside. So
I just want to say we're having a good time in here, but in the other room they were having a really good time.
That's right.
It's graduation season, so we try to open the building for all the local
wonderful.
schools.
It's like a community center.
It's nice.
That's exactly
it's really
right.
nice.
Yeah. All right, Joe, and onwards. And I'd sincerely like to encourage those that are in the back there. Yes, sir, please. Uh-huh. Could you reintroduce yourself just because of the video? Yeah.
I'm Bhagwan Agrawal. I work in healthcare as a data insight consultant. And a little bit more background, I worked in India in public health, particularly occupational health, 5 years, and then I came back. So I would like to share some of my insight working in India. I pick up an example of a town which is about 10,000 people, and the town had a government hospital, so very basic, didn't have much facility, but there were 20 private providers, what we call them registered medical practitioners.
Mm-hmm.
But those were registered RMPs, who simply had some experience working with some doctors and got licensed. And they were, all the experience was paid by out of pocket from the people. Mm-hmm. So they were self-sustained. And then there were midwiferys who used to deliver babies. And those were about 20, like about 10,000 people, there were 20 private care providers and another 15 or 20 were midwiferys. So this is a model, a self-sustaining model. I'm not appreciating that model, but because those people were not properly trained and there were a lot of time misdiagnosis and a lot of tertiary expenditure later stages of disease. But this is an opportunity, an example to learn that if government, if the corporate, and also United Nations come together and provide they sort of start a model, pick up a town as a model, an incubator model, and demonstrate that it could be successful.
Mm-hmm. That's right.
Self-sustaining, without any government help.
Very good.
Because all the expenses were paid by people itself. So if the government, the United Nations and the corporate come together, providing educational training centers so that those practitioners could be more trained, more skilled, and they have the better access from the corporate diagnosis kit or something, and then the United Nations, expanding this model to other towns or other villages.
Absolutely, sir. And thank you for bringing us down to municipal level as well, which is tremendously important. But equally so to highlight the importance of education and training and capacity building. When we as a company go into many ministries of health, they actually say that we're an adjunct to their ministry. And I did not always think about it that way. I think it's very directly so. So education and training, if you look at areas of private-public partnership, is usually one that gets the least resistance from governments, which actually can have, I think any of us would say, one of the highest degrees of societal value, and which is portable, sort of in a way that's irrespective of who actually provided that original training. So, Gary, did you want to comment, please?
Sure. I think you bring up an excellent example for a number of reasons, because also you're speaking about India, which, if you look at the priority of addressing, let's say, what still needs to be accomplished in the original 3 health-related MDGs, 2 countries particularly stand out, India and Nigeria, and that's both a function of the size of the population. But in India's case, it is, my understanding, among the most privatized health systems in the world. Over 70% of health delivery is private, and among the most rural, which makes it very challenging if you think that you have to be able to reach through the informal health sector in rural areas, reaching private clinicians or health workers of some form, ranging from physicians down to much lower level, and acknowledging that their practices aren't necessarily meeting any national, local, or international standards in many circumstances. And I would say, in my experience, most of the planning work that's being done by the global agencies that get involved in global health tend to focus on the public health sector because it's within reach. It's where they can have more of a direct extension to, but there is an increasing acknowledgement without addressing the private health sector, including the informal sector, the goals can't possibly be reached in a place like India. And I won't profess to be an expert on models, but I would say that in some other countries, private investment, private equity investment through organizations, like if you're familiar with the Abraj Group, which is one of the impact investors, are setting up more accredited health delivery systems. And I would like to think, I'm thinking a little bit out of the box now, if private investment could encompass these private practitioners as opposed to excluding them, and build the accreditation system so that they can be properly trained. I have to say the one area of partnership the BD's been more involved in than anything else has been training, whether it's laboratory or clinical practices. If that could be accomplished, it adds value in multiple ways, and I believe because much of this is privately funded, there is a sustainable business model there, particularly in view of the rising income and the burgeoning middle class, which continuously is getting bigger in India. And it would overcome some downsides that exist now. So, for example, because BD is the largest producer of syringes and needles, I personally know that the reuse of injection devices, the improper use of blood drawing devices in not only India and Egypt and Cambodia, many countries, is the leading cause of hepatitis spread. And therefore, some simple interventions, but even those at present are difficult to overcome, although the WHO has a new policy now that will help in that respect.
Perfect. Any other comments from here? Yes, ma'am, in the back. Please, could you present yourself?
Hello, everyone. My name is Nan Shiraya, and I'm from Accenture Development Partnerships, International Development arm of the consulting company Accenture. We're actually one of the board members for GDP Health. And my question is actually building on the concept of financial incentives for public-private partnerships. And I'm curious, what are specific actions that we can take to actually change the mindset of donors or of the private sector, of host country governments, so that, we can build on the hot topics of innovative financing, like development impact bonds, because I feel like these concepts have been around for the past few years, but what is the catalyst for people to actually embrace these concepts? What are some challenges and what can be done to achieve holistic health outcomes?
Perfect, thank you. Simon.
Let me have a start. It's great. It's a great question, and you're right. Many of these ideas, concepts, and instruments have been around for a time and used. I thought when Gary talked about his models and the CSR know-how, and then the societal need and business opportunity through shared value is. It's something that I've thought about a little. When I was at DFID and working on the replenishment of Gavi in 2011. We call these public-private partnerships, and if one wants to look at money, as in where the contributions to these partnerships coming from, it's a pretty small P for private. They're still big public, funded organizations. They're still big donor organizations, but you've got to start somewhere. When it's a complement of competence and ideas and experiences, they're much more sort of equal in terms of how that partnership works. Now, one of the things that we tried to do because we think money counts as well, and so we wanted more private sector investments into Gavi. One of the things the British government did, and we set this up with the Gates Foundation, was thinking about, how might we use public funds to incentivize private sector funds? So we set up something like a matching fund. So I remember cold calling 28 corporations in the UK over a 2.5-month period and selling the Gavi model, and what we wanted to achieve, and said, for every dollar that you put in, we'll put $1 in. If your employee base puts an extra $1 in, we'll put an extra $1 in to match that. Or if your customers put $1 in, so we said, it started small, but I tell you, the first call from the private sector that said we're in, was bigger for us than many of those public sector, because it meant something fundamental and something different. And I think that first replenishment, I don't know, I think we raised about 8 or 10 million from the private sector versus the 4.3 billion that we actually raised. And now I think we're at 300 to 400 million. So from that you can start. So that was just using, sharing risk. It was using, sort of public guarantee. It was using public money as a bit of an incentive to do that. Now I think we can go a lot further on social impact bonds than we have. They're difficult to explain to some people, when you understand this. But when we launched the advanced market commitment, for example, when I went to the launch in Kenya for that, to be able to describe how this front-loading of finance really short-circuited 10 years that you would usually wait for a vaccine that was developed in the USA and the UK to actually get to Africa, and the lives that are saved over that period, that actually is quite appealing. And when we talked about that with the private sector and CEOs, they like it. They like those innovations. The people like it as well. We just haven't done a good enough job of explaining, what some of these innovations can do. But I mean, that was just one example of how we use public money to begin to create incentives for private sector investment.
Let me change a bit. There is another thing that I think is as important as using financing in an innovative way, is that you can also use the financing from the public sector to improve efficiency and of the private sector. And let me give you one example. The example that I provided, I didn't have time to get into the details, but we basically have, as a way of payment, of paying providers of the public sector, we have introduced DRGs, which is basically you pay, instead of paying by number of days that the patient is in the hospital, you pay for solving the case, specific diagnostic, right? So we introduce that. We say, all right, we are going to open business for the private sector, and we will be buying and explicitly buying the 2,000 beds that we need every year. And this is the business, this is the way that we are doing it. But in order to do that, you need to introduce DRGs in your own private clinics or private hospitals. And then by doing that, we are doing two things. We are introducing, of course, a much more effective way of paying, because we are paying for results, and we don't have to worry about how many days the patient is in the private hospital, because we negotiated ex ante what is the rate for that specific diagnostic. But at the same time, we have a system that all the private network of hospitals have developed, basically to introduce all their cases using DRGs, which allows them to benchmark and to introduce efficiency measures in terms of the management of cases that are hospitalized, by introducing the system not only for what they are selling us, but also for all the people that are hospitalized. So there are these type of issues also that I think it's not only from the private to the public, but it's also sometimes from the public to the private as well.
So maybe I'll jump in real quick as well. So at GBC Health, we're actually trying to develop some new mechanisms that are responsive to the points you raised in your question. So one point is relative to social impact bonds. What we feel is lacking is the measurement of the ultimate impact. Most of these are funded prospectively, prior to impact. And we're working to try to develop, we're actually working with Paul Farmer on this, to try to develop the measurement systems such that the sustainable funding can be an outcome of actually demonstrated results, which may also open up the opportunity for more private financing or even private donor financing who'd be interested in reinforcing positive outcomes. Another concept we're working on, and it's an ambitious one, is the concept of social impact credits or health impact credits. And this would be akin to what's been accomplished with carbon tax credits, where there can be an incentive for private investment. It could be in the form of easing regulatory barriers, of accelerating review of new innovations. There are a number of things that don't actually cost anything, but have very substantial benefit. And those credits could become a secondary market as they have a carbon tax credits. One of the things I've been told, somebody maybe here can verify, Tesla makes more money on selling their carbon tax credits than they do on the manufacturing their cars. That's a key element of their business model. I think this is lacking in the health space, and I would actually go broader and link it directly to the SDGs when they're launched, and have the SDG targets become the means by which social impact credits can be afforded to organizations that otherwise would not invest. And the last area is, we talked about millions and billions and trillions. Private capital, there's more than that. There's bazillions out there. There is so much private capital available. How can that be accessed? We're starting to see some early indications of that. And I won't go into detail here, but one of the models we're implementing around maternal and newborn health builds on that, such that it kind of satisfies the restraints we have in putting P&L financing and diluting our earnings, because companies have to perform, by bringing in private capital that can smooth the earnings impact in the near term And then we return that with a nice return to the private investors. We prolong our return way out into the future, but that's okay because we're overcoming our near-term constraint, which would cause us to have to redeploy funds from existing core business operations to new things to solve societal needs. It puts us in a very difficult position. We're actually breaking the code on that. We're in the process of doing so, which I think can unleash a lot of private capital.
Perfect. So the volume is increasing. There's a sign in front of me. I've got one last question, brief, I hope, Ambassador Lang, but you're most welcome. And if you could direct it towards one particular person, that'd be even, yeah.
Thank you very much, Trevor. I'd like to direct you to Simon and pick up on his comment earlier about the partnerships such as Gavi and the Global Fund that are more vertical and have had successes. But then you said that the future is really in the national, subnational level for partnerships. Yet you've got the Sustainable Development Goals that have as one of the targets that will be approved in September, universal health coverage. And I'm wondering what you see as the multilateral global side of trying to strengthen health systems through public-private partnerships, because right now there isn't one entity you would look to for that. Maybe it's the World Bank's new global financing facility to support every woman, every child that will have a broader focus. But do you have any thoughts on where the global scene for this will go to strengthen health systems?
Well, thanks, John. It's a great question, and it is difficult to predict. I mean, I hear some say that we need a global fund for health. But we need this new institution. We need a global fund for education. We need a global fund for agriculture. And I think it can go some way, but it doesn't go far enough. Now, I think the Global Fund and Gavi are remarkable institutions. It was a privilege to work with them. They're here to stay for a while. There's a lot more good work to do. Can we further change incentives within them to think more and more about the building of systems or helping facilitate the building of systems at the national and subnational level? I think we can. Do I think they're going to be the biggest part of their business model? Do I think we're going to see an increasing allocation of and actually, when you think about them, neither of them have country presence. They really work through intermediaries. They're really financing institutions. It's moving. So we've got to think about, well, what are the other mechanisms for doing this? It does come down to national jurisdictions. Now, I guess one looks at those countries where we've seen success and say, how do we figure out ways of replicating that? I think it comes down to thinking about how new technologies will do this. So we've talked about the human workforce a lot. I mean, I hope we hear a little bit from Debbie Shetty tomorrow about some of his ideas about how we further train at lower cost, a workforce that is able to work and deliver services at different levels. I think the global architecture in its present form, everybody says, isn't fit for purpose, and it isn't how we would design the system if we had a clean sheet of paper. But it is what we've got, and I'm not confident we're going to see massive, reforms there. I think GFF, will. I do think finance drives a lot of this. I would like to see a further attempt at the bank and WHO and other parts of the UN figuring out a more coherent way of supporting countries. I'd also like to think of ways in which we really look at capacity building in a new way at the country level too. I mean, Joe, you were talking about the best partnerships are strength to strength, but we don't have that parity. And I remember, and I can say it because it was in a public forum at the spring meetings, I heard General Electric, a vice president, say that they spend $42 billion a year on negotiations alone. That's just a mind-boggling sum of money on negotiating where they do business, how they do business, where they build plants and do things. And you think about, well, so where's the parity in negotiation? So maybe some of these global institutions, become brokerage houses. When I talked earlier about, from when I was at DFID, our inability to really engage effectively with the private sector for all sorts of reasons. Actually, just our engagement in some of these public-private partnerships at a global level, are building some of those alliances, are building nomenclature and language, are building relationships where we can talk, which I don't think we had 8 years ago. So I think there's a role there for them to continue to perhaps broker some of these public and private interactions.
Perfect, Simon. Thank you very much. A profound thanks to all of our panelists. And Jeanette, thank you very much for coming all the way from Santiago, particularly to be with us and share Chile's experience today. We've learned a lot. We've talked some best practices. We've certainly talked a fair amount on the lessons, all focused around incentives. A lot more ahead. We've got lunch in the back, and if you can't beat them, join them out on the street. So again, thank you all very much for a highly participative session and illustrative in many key respects. Thank you.